Hello everyone, very good morning to all of you. So today we are going to see about gingiva, which is one of the basic tissues of the periodontium. So we'll be discussing about the entire periodontology, the core aspects of perio. So I want to make sure that if you are strong in your basics, you can build over it. You can build anything over it, but you have to be very strong in your basics. Okay. So today the very important basic tissues of the periodontium we are going to talk about is gingiva. Okay. Most of you would have been confused with a few terminologies and few things about gingiva, which makes you very difficult to understand when it comes to surgical aspect. Okay, so today we are going to break down every aspect of gingiva so that you have no doubts in gingiva, so that whenever I talk about keratinization or pigmentation or color, it's going to be very clear because you are going to be very strong in your basics. Okay, fine. Okay, so as I told you, the periodontium basically has four tissues, isn't it? Gingiva, PDL, cementum, and bone. Okay, of all these, two will be soft tissues and two will be hard tissues. What are the soft tissues? Exactly. So these two will be soft tissues. Okay, and these two will be hard tissues. So in this class, we are going to take a look about gingiva. Okay, as we all know, gingiva is a soft tissue. Okay, it is firmly attached to the bone. A part of gingiva is firmly attached to the bone, and a part of gingiva is not firmly attached, it is loosely attached to the bone. And also we are going to discuss about what are the various parts of gingiva, which will be the macroscopic features of gingiva. See, macroscopic, the word implies you're going to see through your eyes, right? Okay, so the first macroscopic feature will be marginal gingiva. Okay, as the name implies, marginal means it forms the terminal border. Okay, it forms the terminal border. It is unattached. Okay, it is unattached. So am I right in saying that since the marginal gingiva is unattached, it forms a space between the tooth and itself? Obviously it will form a space because it is unattached. So I'm going to call that space or a crevice as gingival sulcus. Okay, the space or crevice which is formed by the marginal gingiva is called as gingival sulcus. What is the significance of gingival sulcus? Exactly, I'm going to insert my probe into the gingival sulcus. Okay, now the marginal gingiva is 1 mm wide. Okay, so what is the significance of a gingival sulcus? Okay, most of the times we will be confused with the terminologies what is PPD and what is cal. Okay, so PPD is nothing but periodontal probing depth, where I'm going to insert the probe into the sulcus. I'm going to measure the value and I'm going to write it down irrespective of whatever it may be. Okay, so what will be the normal probing depth? The normal probing depth will be 2 to 3 mm. Okay, anyone watching this video is germ free? Do you think that you're germ free? Even I brush 4 times a day, definitely I'm not going to be germ free. Okay, everybody will have invariably some kind of germs, some kind of inflammation. Okay, then why they coined probing depth as 0 m for germ free animals? Okay, is there anyone germ free? Do you think that anyone is germ free here? Maybe lab animals. Okay, animals which are grown in vitro for any pharmacological purposes, they might be germ free, but other than that nobody is germ free. Everybody will invariably have gingivitis. So don't write probing depth as 0. Okay, your probing depth will never be 0. It can be, normally if you have gingivitis alone, it can be 2 to 3. If you have recession, it can be 1. It starts from 1. I'll tell you how. Okay, so see, you take a look at this picture. Okay, So this is the cemento-enamel junction. What is cemento-enamel junction? The point where the enamel and the cementum meets. 60% of the times your cementum is going to overlap the enamel. Okay. So what I'm going to do is I'm going to tell you three scenarios. Okay. Let us assume this is a normal patient. Okay. This is a normal patient who is not having any bone loss. Okay, and no attachment loss. Okay, so what I'm going to do, I'm going to take a Williams probe. What is a Williams probe? Williams probe is a first generation probe. You have markings from 1 to 10 except 4 and 6. Why? To avoid confusion. Okay, so I'm going to insert the Williams probe. I'm going to mark the probing depth. Let us assume 2 mm. Okay, and I'm going to write it as normal. Okay, now how do you assume that this 2 mm is actually a normal thing? Okay, now I'm going to tell you a very important thing, how this clinical attachment level is calculated. Okay, so let us assume this is the cemento-enamel junction. Okay, this is the cemento-enamel junction, and this portion of gingiva is called as the marginal gingiva, right? Because it is unattached, it forms the sulcus. So the clinical attachment level depends upon the position of the marginal gingiva. Okay, now I'm going to tell you three positions of marginal gingiva. One is, in this case, you see the marginal gingiva is coronal to CJ. The marginal gingiva is coronal to CJ. What does that mean, sir? It's very simple. A patient comes to you, the patient might have pocket or might not have pocket, but I'm going to just look at the position of the marginal gingiva, whether the patient is having any tissue loss, any soft tissue loss, or any kind of recession. If the patient is not having any recession, that means the papilla is intact, there is no black triangle, there is no interdental spaces, there is no tissue loss, there is no recession. Okay, in those cases what I'm going to do is I'm going to measure the probing depth, and I'm going to measure the distance from the gingival margin to the CJ. So say for example, a normal gingivitis patient, okay, you and me probably, I'm going to probe, I'm going to take a Williams probe, I'm entering into the sulcus, it's 2 mm, there is no tissue loss, there is no recession, there is no radiographic bone loss, I'm going to write cal as 0. Okay, but it might not go well with everybody, right? Say for example, some patients, okay, some patients, the same scenario, okay, the gingival margin coronal to CEJ, okay, gingival margin is coronal to CEJ, but the patient is having pocket and bone loss. Predominantly you see these kind of situations in aggressive periodontitis patient. Okay, there will be no recession most of the times, but you see pocket of 7 mm. Okay, how to calculate cal in this patient? So this patient is also having gingival margin coronal to CEJ, but the difference between these two is this patient does not have any pocket or attachment loss or bone loss, whereas this patient, if you see, this patient is having bone loss and attachment loss, but the gingival margin is coronal to CEJ. That means there is no interproximal soft tissue loss and recession. Okay, how to calculate cal? Very simple. I'm going to do probing depth. Say for example, my probing depth is 7 mm. Okay, my probing depth is 7 mm, and what I'm going to do next thing is I'm going to measure the distance from the gingival margin to the CEJ. Let us assume this is 2 mm. So I'm going to subtract the distance, the probing depth and the distance from the gingival margin to the CEJ, which means for this patient cal is 7 mm minus 2 mm, which is equal to 5 mm. Okay, a patient with the gingival margin coronal to CJ, but he or she is having pocket, so I'm measuring the pocket depth, 7 mm, and then I'm going to subtract it with the distance from the gingival margin to the CJ, and I'm going to give it as cal. How to detect CJ? Very simple. You take a probe, you run through the crown, and there'll be a sudden dip. Okay, that is called as cemento-enamel junction. 60% of the times cementum will overlap the enamel. Okay, so this is the first scenario what you are seeing: a patient with the gingival margin coronal to CJ but presence of pocket, and we are going to measure the cal. The next scenario, okay, the next scenario is patient is having bone loss. Okay, patient is having bone loss, but the gingival margin is at the level of CEJ. Okay, this is a very tricky scenario, right? I see some amount of tissue loss. Okay, I see some amount of tissue loss. I see some amount of bone loss, but when I probe, it's going to be 3 mm or 2 mm. What to do in this scenario? So the probing depth in this case will be 2 mm or 3 mm, but the patient will be having, definitely the patient is having soft tissue loss, right? So this portion of the soft tissue is lost, isn't it? So there's definitely soft tissue loss. There is some amount of crystal bone loss, but the probing depth is 3 mm. How to calculate cal? Very simple. These kind of patients, I'm going to call them as hidden recession. What is it? Hidden recession. Or progressive periodontitis. Hidden recession or progressive periodontitis. What do you mean by hidden recession or progressive periodontitis? Is there is soft tissue loss, but I'm not going to know the end point of the progression of the disease, which means 5 people are starting to run. I don't know who will come first. So I'm assuming all the 5 as the first price. Okay, so in this case, the tissues are starting to get destroyed. The bone loss is going to begin, but I don't know when the disease will stop. So I am assuming PPD equal to cal. Okay, for this patient I am assuming PPD equal to cal. So patient with black triangle, we take that example. Okay, patient with black triangle. What is black triangle? Loss of your interdental papilla. There will be a space between the 2 teeth, that is called as black triangle. A patient with black triangle, there is interproximal soft tissue loss, but the probing depth is 2 mm. I am going to assume that patient is having hidden recession or a progressive periodontitis. So I'm going to mark them as PPD equal to cal. Very simple, right? So the next scenario, I think everybody will know it. Okay, patient is having gingival margin apical to the CJ. What is this condition called as? Brilliant. Gingival recession. What it is called as? Gingival recession. What is gingival recession? You should be very precise. Okay, gingival recession is the apical migration of the marginal gingiva below the level of CJ. Very simple, right? So the marginal gingiva migrates below the level of CJ. That is called as gingival recession. Okay, so how to calculate cal in gingival recession? Very simple. I'll measure the distance from the CJ to the gingival margin, and I'm going to plus it with the probing depth. Okay, so say for example CJ to the gingival margin is 3 mm and the probing depth is 2 mm. What will be my cal? My cal will be 5 mm. This is how you calculate cal in recession patients. So a patient who is not having recession, I'm going to subtract it with the distance from the gingival margin to CJ. A patient who is having marginal gingiva at the level of CJ, where there is interproximal soft tissue loss, I'm going to assume that it is equal to cal. So PPD equal to cal. And a patient who is having gingival recession, that is the marginal gingiva migrated apical to the level of CJ, I'm going to add the distance from the CJ to the gingival margin, and I'm going to plus it with probing depth. So only for these patients the probing depth can be 1, can be. Okay, so this is how you calculate ppd and cal. Okay, so the marginal gingiva, it forms the sulcus. So in the sulcus only we are doing all these kind of things. Isn't it amazing, right? Okay, what probe we use n number of probes. We most commonly use Williams probe, 1 to 10, 4 and 6 are missing to avoid confusion. Other probes, say for example a patient is having abscess, the probing depth might extend about 10 mm. In those cases I'm going to use UNC 15 probe. Okay, UNC 15 probe, markings from 1 to 15, dark bands at 5, 10 and 15. So I use this probe in case of probing depth more than 10 mm, where I cannot use the Williams probe. Okay, all the Williams probe and the UNC 15 probe are first generation probes. Okay, very good. So now moving on to the next aspect of gingiva, which is nothing but attached gingiva. Okay, which is nothing but attached gingiva. So as the name implies, this part of gingiva is completely firmly attached to the periosteum of the alveolar bone. Okay, periosteum is outer covering of the alveolar bone. So the attached gingiva is firmly attached to the periosteum of the alveolar bone. What is the significance? Why a gingiva should be attached? Let everything can be a marginal gingiva, right? So that you can easily insert the probe and there is no need to calculate ppd and cal, right? Very simple. Imagine when we are speaking and there is no attached gingiva. Okay, when I speak, if there is no attached gingiva, the entire gingiva is going to move. What will happen if the entire gingiva moves? Obviously there will be food entrapment, food lodgement, which will lead to pocket, which will lead to periodontitis, which will eventually lead to bone loss and tooth loss. So this part of attached gingiva is very helpful to maintain or to resist, okay, to resist frictional forces, to resist tensional forces, and also to resist inflammation. Okay, so resist frictional forces, tensional forces and resist inflammation. Okay, frictional tensional forces is fine, sir, because it is firmly attached, so it resists the pull of the frenum, the muscles of mastication, so it helps to hold the gingiva in place. That is fine, sir. How come it resists inflammation? Very simple. See, I'll tell you the basic structure of a tooth. Okay, so okay, see, everybody would have been familiar with this, but I'll just brush it up. Okay, so this black portion is your junctional epithelium. Excellent, this is your junctional epithelium, and below these junctional epithelium you see dot 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 things, right? What is that? Exactly, that is called as gingival connective tissue fibers. What is it called as? Gingival connective tissue fibers. And obviously everybody would have known this. This is your periodontal ligament and this is your alveolar bone. This portion is called as the crest of the alveolar bone, alveolar crest. Okay, and we all know that the combination of the junctional epithelium plus the gingival connective tissue fibers is called as biological width. Biologic width. Now you have to understand one thing. The terminology has been removed. Okay, there is no longer the term biological width. It was removed way back in 2017 or 18, and they have replaced it with a term called as supracrustal tissue attachment. Okay, supracrustal tissue attachment. Now they will ask you questions like, what is a normal supracrustal tissue attachment? You will know the answer, but because you are not updating yourself or you are not aware of the familiar new terminology, you get to lose the answer. I'm damn sure if you're not answering a very basic question like the biological width, which is replaced by supracrustal tissue attachment, you will be pushed at least 1000 to 2000 ranks, and you should answer a very difficult question which these 1000 to 2000 students will not be able to answer. That is a bit sticky situation, right? So don't make mistakes in your basics. Okay, so supracrustal tissue attachment is nothing but biological width. What is a normal biological width? Excellent, 2.04 mm, 0.97 mm plus 1.07 mm. Okay, so this is junctional epithelium, this is gingival connective tissue fibers. So you should be always familiar with the new terminologies, right? So what is the significance is very simple. See, this portion of the gingiva, okay, this portion of the gingiva is attached gingiva, right? This is your attached gingiva. So the attached gingiva is firmly adhered to the bone with the help of fibers, right? With the help of fibers. So attached gingiva with the help of fibers, it is firmly attached to the bone. What they tell is these fibers are nothing but collagen fibers, right? Predominantly type 1 and type 3 collagen fibers, which helps to attach the attached gingiva to the periosteum of the alveolar bone, is extremely dense. Extremely dense. What is the significance of a dense collagen fiber? Very simple. A dense collagen fiber will resist the products of inflammation or products of bacteria to enter through itself. So when the bacterial products does not enter, there's going to be minimal inflammation. So that is the reason why an attached gingiva helps to fight against the bacteria, because of the presence of a dense collagen fibers. So when I'm having a dense collagen fibers, which will be seen in patients who are not having any periodontal disease, I'll be more resistant to bacterial products or bacterial endotoxins. So by that, I'm ensuring that I'm safe. So this concept of a dense collagen fiber, which will help the body to fight against the bacteria and to prevent the minimal invasion or to prevent the entry of the bacteria, is called as the tissue barrier concept. Okay, what is this concept? Tissue barrier concept. It is given by Goldman and Kogan, 1979. Okay, so the tissue barrier concept is very simple. A dense collagen fiber resists against inflammation. It is very well said that whenever there is a pocket formation, there is going to be a destruction of collagen fibers. So there is going to be loosening of the collagen fibers. So a loosened collagen fiber or loosened connective tissue will easily permit the entry of the bacteria compared to your dense collagen fibers. This is where the whole concept of tissue barrier comes in. So the tissue barrier concept is the one that says that collagen fibers are extremely resistant to inflammation. That is the reason why I already told you that attached gingiva resists against inflammation. Okay, so the next time you read something, you find out why the reason is being used. Okay, everything has a logic and everything has a reason. No terminologies can be given just like that. Okay, everything will have a logic and evidence. Okay, now as you see here, this portion, you see a small demarcation here. I'll draw half of it and so that you can recognize the other half. Okay, you see this demarcation, that is the mucogingival line. That is the mucogingival line. Okay, So a mucogingival line is seen when the attached gingiva ends or the mucogingival junction begins. This is where we deposit LA, right? Infiltration. Okay. Now, how to calculate this attached gingiva? How to calculate the width of attached gingiva? How to calculate this width of attached gingiva? Very simple method. Okay. You have to measure the distance from the gingival margin. You have to measure the distance from the gingival margin to the mucogingival junction or the mucogingival junction line, which I've shown you here. Okay, and with this I'm going to subtract the probing depth. So by doing this, what I'm doing, I'm measuring the distance from the gingival margin to the mucogingival junction. Okay, and I'm going to insert the probe into the sulcus and I'm going to do probing depth measurement, and I'll just subtract it with this value. Okay, that gives me the width of attached gingiva. Very simple way to measure the width of attached gingiva. Okay, what is width of keratinized gingiva? Width of keratinized gingiva is, see, as I told you, in width of attached gingiva, I'm measuring the distance from the, I'm calculating it by measuring the distance from the gingival margin to the mucogingival junction, and I'm subtracting it with the probing depth, right? If I don't subtract it, that is, if the distance from the gingival margin to the mucogingival junction is called as the width of keratinized gingiva. So the entire aspect from the gingival margin to the mucogingival junction is the width of keratinized gingiva. From I'm measuring the width of keratinized gingiva, and if I subtract the probing depth from the keratinized gingiva, that gives me the width of attached gingiva. Very simple, right? Okay. So we have learned about a few terminologies: width of attached gingiva and width of keratinized gingiva. So what is a normal value of a width of attached gingiva? Maxillary anteriors, it's going to be 3.5 to 4.5 mm. Maxillary premolars and posteriors, it's going to be 1.9 mm. Mandibular anteriors, it's going to be 3.3 to 3.9 mm. And mandibular premolars or posteriors, it's going to be 1.8 mm. Okay, what is the significance? Why we should know these values is, see, a few authors have suggested that it is mandatory to have some amount of width of attached gingiva to be normal, or some amount of attached gingiva to maintain the health of the gingiva. Okay, in that way, a lot of authors have proposed numerous concepts or numerous school of thoughts on what should be the normal width of attached gingiva. These values are for you to know what, to know at least, or to come to an idea of what will be the normal width of attached gingiva. But most of the authors suggested that 2 mm of attached gingiva is more than sufficient to maintain the gingival health. Okay, just know this also. But you should not tell that 2 mm of gingiva is enough. So whenever I see a 2 mm option in the MCQ, I should mark it no. You should know the exact value, and also you should know the concept and school of thoughts behind that. Okay, you cannot go and refer width of attached gingiva author. So I'm just compiling it and I'm just giving it to you. Okay, so maxillary anteriors 3.5 to 4.5, maxillary premolars 1.9, mandibular anteriors 3.3 to 3.9, mandibular premolars 1.8. So the least will be your mandibular premolars 1.8 mm. Very good. Okay, so what I told you is this method, that is the conventional method. Okay, so the conventional method is, I'm measuring the distance from the gingival margin to the mucous junction, subtracting it with probing depth. Done and dusted. There are other ways also to measure the width of attached gingiva. Okay, you take a look at this picture. This is called as roll test. I'm taking a probe from the mucogenial junction. I'm just rolling the instrument, and the point where it hits, okay, that determines the mucogenial junction. That is the end of the mucogenial junction, or if you come here, that's going to be beginning of the mucogenial junction. So you see this here, this is the mucogenial junction. So I am just calculating this point, and I'll use another probe to measure this value, and I'll separate it with the probing depth. Okay, this is called as roll test. Okay, the next one, staining of the gingiva, Schiller's potassium iodide. Okay, staining of the gingiva with Schiller's potassium iodide. What will happen if I stain with Schiller's potassium iodide? Is the gingiva, as you see here, it will take up the brown pigments. Why? Because of the glycogen content. Okay, so the attached gingiva takes up the brown pigment because of the presence of the glycogen content. In that way, I'm going to calculate the width of attached gingiva. Okay, the next one is going to be local anesthetic test. What do you mean by local anesthetic test? See, you would have noticed whenever you give an LA infiltration, it's going to be swelling up like a white balloon thing. Why? Have you ever imagined why? Very simple. So when I'm going to insert the needle, at the mucogingival junction, there is going to be presence of more elastic fibers. Okay, so my alveolar mucosa will have more elastic fibers. So because of the elastic fibers, whenever I give an LA, it is going to swell up. Okay, and because your gingiva, as we all know, the gingiva is a dense collagen fibers, it is just going to blanch. So when I give an LA, the portion which swells up will be your alveolar mucosa, and the portion of the gingiva which blanches will be your attached gingiva. Why blanching occurs? Because of the dense collagen fibers. This is local anesthetic test to determine the width of attached gingiva. You see here. Okay. Okay. Another one latest finding is use of ultrasonic probes. So they are using ultrasonic probes to enter into the sulcus. It measures the width of attached gingiva using the reflections from the bone. Okay, this is the latest finding, use of ultrasonic probes. Okay, so these are all the few ways where you can measure the width of attached gingiva. Conventional pull test or a tension test, you can say, and Schiller's potassium iodide taking up the stain, local anesthetic test, and ultrasonic probes. Okay. Okay, now we are moving into another part of gingiva that is called as the interdental gingiva. Interdental gingiva. Okay, so interdental gingiva, very simple. Interdental gingiva, in the anteriors, it will be, as you see here, it will be extremely sharp. Doesn't it look like a pyramid? Yes. So the interdental gingiva is a part of gingiva which is present between your tooth at the contact point, and it fills the interdental spaces. What will happen if there is no interdental gingiva? Imagine if the patient is having no interdental gingiva. It will be extremely anesthetic, right? You see black spaces throughout the oral cavity. It will be extremely anesthetic. So this interdental gingiva, at any cost in the anteriors, especially in your anteriors, it should be preserved, isn't it? So when I say a surgical technique, and when I say a surgical technique which preserves the interdental gingiva, you should know, yes, interdental gingiva, it is pyramidal in shape, it fills the internal spaces. At any cost, I should preserve it so that I can prevent the formation of a black triangle. You should be very careful in this. Okay, now this interdental gingiva, it fills the embrasure spaces, fills the contact points, and anteriorly it is going to be pyramidal in shape, and posteriorly there it will be caul shaped. What do you mean by caul shape? Is very simple. You see, you take a look at this picture. Take a look at this picture. So this is the lingual papilla, This is the facial papilla, and this facial and the lingual papilla, they meet interdentally, and this intervening portion contains attached gingiva. This intervening portion contains attached gingiva. So, does your internal papilla be very loose or it will be separated? No, because it has a connection. In the middle there will be attached gingiva. So if I want to break the internal gingiva, I should give an incision so that I release the attached gingiva, and then only it will split up. Okay, so the internal gingiva, interproximally posteriorly it is called shape, there will be a small depression, and the intervening portion will have the attached gingiva. That is why your internal gingiva is not loose, or it just not separated like your marginal gingiva. Okay, so that is the reason, because the intervening portion has attached gingiva. Okay, very good. So I'll tell you a very simple classification of black triangle or gingival embrasure classification. Okay, so you just remember this classification, because when I talk about chemical block control agents or mechanical block control agents, and I tell you about this kind of papillary patients, class 1 patients, class 2 patients require this. Okay, very good. So first one is this first line is your contact point. This is your contact point. Okay, which means the two teeth is going to intersect there. The second most line is your interproximal CEJ. Interproximal CEJ. The third point, see, the thing I'm marking in different images is to avoid confusion. Okay, everything will be, it will apply for the all the images. Now the third point, as you see here, this will be your facial CEJ. Okay, so interproximally, as you during your tooth carving, you would have noticed, right? Say for example, your interproximally, if you take, the CEJ will be a little bit up, like something like this. So you see there will be a, interproximally it will be a little bit more or coronal than your facial, right? Interproximally it will be a little bit higher. So that is what we are mentioning here. Interproximally it is little bit higher or lower than your facial CEJ. Okay, so take a look at this patient. This patient is absolutely normal. This patient is not having any kind of interproximal attachment loss. And take a look at this patient. Okay, take a look at this patient. This patient is having some kind of tissue loss. Okay, some kind of tissue loss. But this tissue loss does not extend to the interproximal CEJ and the facial CEJ. Just the contact point is not having tissue. Okay, this is class 1. Class 2, if you see, there's going to be tissue loss. There's going to be tissue loss which extends to your interproximal CEJ. And class 3, if you see, there is going to be tissue loss which extends to the facial CEJ. There's going to be complete tissue loss. So what is the significance of this? Very simple. Always remember that patient who is not having interproximal tissues will have bone loss. Example, diastema patients. You see diastema, there will be loss of internal papilla, there will be definitely bone loss. Why? Because always remember your gingiva will follow the contour of the bone. So whenever I am having bone loss, I will have soft tissue loss. So the gingiva is going to come down and the bone is going to showcase its use. Say for example, if the bone is like this and the gingiva will be exactly like this, pyramidal in shape. The bone is like this, the gingiva will obviously going to come down. So whenever I see an interproximal soft tissue loss or interproximal spacing, black triangles, there will be bone loss. So these patients should have good maintenance to prevent the progression of the disease Otherwise, this might lead to increased bone loss and eventually which might lead to tooth loss. Okay, very good. So now coming to the color of the gingiva. So normally the color will be coral pink. Okay, the color, if you see, it depends upon the vascular or the vascularity and the pigments. What pigments? Especially melanin. So you take a look at how come these two varies. Let us imagine a patient with periodontitis. Okay, what is itis? Inflammation. Periodontitis, inflammation of the periodontia. Cardinal signs of inflammation: bleeding, pain, swelling, or eat. All these is going to be there, right? So patient with periodontitis or a gingivitis is going to have increased blood flow, vasodilation, is going to have reddish gingiva because of the increased vascularity, stasis of the blood. There can be color change. So in case of a patient with gingivitis or periodontitis, the color can be erythematous or bluish. Why bluish? Because of the stasis of the blood. How come stasis occurs? Steps in inflammation. I'll tell you how. Okay, when I talk about host response to inflammation, host response to bacteria, I'll talk about how this stasis of blood takes place and why that is why the bluish thing comes out. So whenever there is an pathology in the gingiva, it is going to be erythematous or bluish in color. So the color depends upon the vascularity and the pigments. What is a pigment? Melanin is your pigment. Melanin is a physiological pigment. So okay, now I'm raising a question. Take for example, this patient comes to your clinic or your hospital and you're going to do depigmentation, gingival depigmentation. Is it an aesthetic procedure? Obviously it is an aesthetic procedure. Gingival depigmentation. I'm asking you a simple question. Imagine I am the patient, I'm coming to your clinic, I want to do depigmentation, and you're planning to do a depigmentation using whatever method you prefer. That is not an issue. But I would like to ask you one question: is this permanent solution? Whatever you're doing, is that a permanent solution? What do you answer? The answer will be very simple. It is not a permanent solution. It is reversible. So if I do a depigmentation procedure, it is an aesthetic procedure. Say for example 5 to 6 months, it will come back. If you are not telling this, they'll come and sit for every 6 months and you have to do the procedure for free. Okay, so gingival depigmentation is reversible or it will come back. Why? Because very simple, because the gene for the melanin production, okay, the gene for the melanin production is located in your connective tissue. Okay, so the gene for the melanin production is located in the connective tissue. In gingival depigmentation, I am just scraping the epithelium. I am not touching the connective tissue. So the gene which is responsible for the production of melanin is undisturbed. So what happens over a period of time? It will look, oh, there is no melanin, I'm going to synthesis, so it will produce. Okay, now coming to the size. Okay, so the size of the gingiva mainly depends upon the cellular contents. What do you mean by cellular contents? Cellular contents means predominantly the fibers and the cells. Okay, say for example a patient comes to you with this gingiva, it's absolutely normal. So you rate it as normal, send the patient, and in case you need, you can do scaling and send. Imagine this patient comes to you. It is very obvious that this patient is having gingival enlargement, right? So there is going to be an increased production of something which lead to this. You agree with me? Yes. So imagine collagen being the principal organic content of our body, of our tissues, basic tissues, especially type 1 and type 3. The destruction is lost. Okay, type 1 and type 3. Imagine if there is no collagenase. Imagine if there is no collagenase. There is no collagen destruction, only production by fibroblast. What will happen when there is only production, no destruction? It's going to result in swelling or increase in size, hypertrophy. So am I right in saying that a patient with gingival enlargement, there will be some malfunctioning or some disturbances in collagenase enzyme? Obviously, right? So these patients need a specific treatment, which I'll tell you in the treatment aspect. Okay, so this is enlargement patients. Depends in the size depends upon the cellular contents. Okay, the size can be normal or enlarged. Okay, very good. Now coming to the contour. The contour of the marginal gingiva is scalloped. The contour is going to be scalloped. In case of any inflammation or any pathology, it is going to be flat. Okay, so the contour normally it is going to be scalloped. In case of any inflammation, is going to be flat. Next is your shape. As I told you, anteriorly it is going to be pyramidal in shape, and posteriorly it's going to be col shaped. In case of any inflammation, it's going to be blunt, which means it will not be this, it will not be this sharp. Okay, instead it will be blunt. It will be something like this. Okay, so in case of any inflammation, the shape is going to be blunt because of the cohesiveness, because of the increased inflammation, edema. Whenever there is an edema, there is going to be loss of cohesiveness. I'll tell everything in the future chapters. Okay, so whenever the tissue is inflamed, there's going to be edema, there's going to be loss of cohesiveness, so it will become more bulk, so it will lose its shape, so that is why it becomes blunt. Okay, now coming to the consistency. So normally the consistency will be firm and resilient. In case of any inflammation, okay, in case of any inflammation, obviously there will be increased vascular permeability. Okay, there's going to be increased vascular permeability. There is going to be edema. Okay, whenever there is inflammation, there will be increased vascular permeability, there will be edema formation. So when there is an edema formation, it will not be firm and resilient, it will be soft and edematous. Soft and edematous. So normally a gingiva without any inflammation, it's going to be firm and resilient. In case of any inflammation, even if it is mild or severe, it is going to be soft and edematous. Okay, very good. The next one what you're going to see is stippling. So stippling, if you see, these are called as stipplings. What does it represent? We all know orange peel, right? So this is the orange peel appearance. Why this orange peel appearance come? Very simple. It is mainly because of the projections of the papillary layer of connective tissue into the epithelium. Into the epithelium. So, whenever there's going to be projections of the papillary layer of the connective tissue. Connective tissue has two layers, papillary, reticular layer. So the papillary layer is the one, say for example, this is your epithelium, okay? So this is your connective tissue. The connective tissue will have two layers. One is the papillary layer, which is present very close to the epithelium, or which is going to touch the basement membrane and the epithelium, and the center portion will be a reticular layer. Leave the reticular aspect. So the papillary portions, which is in very close contact with the epithelium, is going to extend some projections into the epithelium, right? So these projections of the papillary layer of the connective tissue into the epithelium is called as the is what appears as stippling. Okay, what is the significance of stippling? Stippling is usually seen in attached gingiva and some center portions of interdental gingiva. Okay, stippling is seen in attached gingiva and in some center portions of interdental gingiva. What is the significance of stippling? Very simple. Whenever I am going to have inflammation, there is going to be no stippling, there's going to be loss of stippling. So in case of inflammation, there's going to be loss of stippling. Okay, so when I take a gauze, dry the gingiva, if there is presence of stippling, there is no inflammation. If there is absence of stippling, there's presence of inflammation. So it's nothing but it's the projections of the papillary layer of connective tissue into the epithelium. Very simple, isn't it? Very good. Okay, now moving on to the microscopic features of gingiva. Okay, now imagine, just imagine, all the structures which you have seen till now can be seen through the naked eye. That is why it is called as macroscopic. And now whatever I'm going to tell you, you cannot see that through your naked eye. Okay, which means I have to see it in a microscope, and then only I can visualize the structure. Okay, as the name implies, microscopic features. Okay, now the first microscopic feature what you're going to see is the epithelium. Okay, most of the times we will be very confused with the term keratinization. What is non-keratinization, what is para-keratinization, and what is the significance of this keratinization? And I am very much confused, sir. After this video, you should be never ever get confused with keratinization. Okay, very simple. So you take a look at the skin. Okay, our normal skin, it is lined by stratified squamous epithelium. Is it keratinized or non-keratinized? It's keratinized. Okay, so the skin is keratinized stratified squamous epithelium. Okay, so what is the significance of a keratinization or keratinized epithelium or keratin? What is the significance of a keratinization? Very simple. Any epithelium which is keratinized is a water barrier layer. Say for example, we take bath, right? Does the skin completely takes the water and soak and it becomes wet? No. So it acts as a water barrier. Imagine if an epithelium is not keratinized, will it have waterproof barrier? Obviously no. That is what is happening in gingiva. Okay, we'll just see how the process of keratinization takes place, and I'll tell you why the junctional epithelium or the circular epithelium differs from your keratinized epithelium. Okay, okay, first of all I'd like to tell you any epithelium. Okay, any epithelium, whatever epithelium you take, it will have cells. It's self understood, right? Any epithelium, it will have cells. Now, similar to our body skeletal system, each cell will have a skeletal system that is called as cytoskeleton. That is called as cytoskeleton. And this cytoskeleton is made up of cytokeratins. So cytokeratins are basically proteins which will help to form the cytoskeleton. Cytoskeleton is essential because it is the what is it? It is a major component of a cell. Like if you don't have bones, we don't have a body. So bones are essential to give shape to a body, right? Similarly, cytoskeleton gives shape to a cell, to an epithelium, and these cytoskeleton in turns gets nutrients from the cytokeratins. So cytokeratins are basically proteins. Okay, so this entire setup, okay, this entire setup of sorry this entire setup of a cell with the cytoskeleton and the cytokeratin is called as the keratinocyte. What is it? Keratinocyte. Don't get confused, okay? Every epithelium will have a cell. Cell will have a skeleton as human beings. Skeleton is made up of proteins, cytokeratins. These cytokeratins are nothing but proteins which will help the cytoskeleton to compete itself or to survive. Okay, so this entire setup of a cell, cytoskeleton and cytokeratins, is called as keratinocyte. What is the function of keratinocyte? Very simple, it produces keratin. Okay, so now I'm going to tell you how this cytoskeleton is going to affect in the process of keratinization. Okay, so as we all know, there are four layers of skin. What are they? Stratum, basal, next stratum spinosum, stratum granulosum, stratum corneum. Okay, these are all the four layers of a keratinized epithelium. Okay, what happens inside an epithelium that makes it keratinized? Okay, I'll tell you in a very story format, so it will be very simple for you. Okay, so stratum basal, okay, stratum basal will have cells, will have cytokeratins or keratinocytes. Okay, it will be in a very low differentiating phase. What does that mean? Which means the cells in the stratum basal will not differentiate. Then what is the function of stratum basal? Is it will synthesize or synthesis DNA and help in mitosis. Okay, it will help to synthesis DNA and help in mitosis. Okay, so by this the cell will start to proliferate, start to increase their number, and it will move upward. Okay, what is the upward layer? Stratum spinosum. So these keratinocytes or cytokeratins, they start to multiply, they start to divide, they move upward. What is the upward layer? Stratum spinosum. So during the stratum basal, the cell will be extremely normal with a normal shape. The size of the nucleus will be normal. All the components or organelles of the cell will be present. So all the organelles will be present. So it just synthesis DNA, helps in mitosis. So it is telling that, okay, I will just help you to move forward, I will not divide or I will not multiply, I will help you to move forward and you divide by yourself so that I give you some food to divide. That is mitosis and DNA. Okay, so stratum spinosum. So the cells of the stratum spinosum will be polyhedral in shape. It changes to polyhedral in shape. Okay, and very important thing is, while moving upward, let us imagine a cell from stratum basal moves to stratum spinosum with the help of a ladder. Okay, that ladder is called as desmosomes. Okay, so there are two types of desmosomes: membrane proteins and proteins of attachment. Okay, so the membrane proteins are nothing but desmocolins and desmogleins. These are desmoplakins or placoglobin. So see, the names are only looking very tough, but the function is very simple. Cell to cell attachment is by desmosomes. A cell moves from the stratum basal to stratum spinosum with the help of desmosomes. There are two types of attachment proteins: membrane attachment proteins and proteins of attachment, and these two help a cell to move upward and also to stay united. Okay, so the cells of stratum spinosum are polyhedral in shape, and they start to multiply. How the filaments, that is your cytokeratin are nothing but filaments, intermediate filaments. Okay, so these cytokeratins will be extremely dense. Any cell which is dense, there is going to be increased activity of the cell. So the cell is functioning, the cell is trying to produce a protein, which in this case is keratin. So normally in stratum basal, a cell is normal in shape with the normal organelles, and it just synthesis DNA and mitosis. So there's going to be cell division in the upper layers. So as the cell from the stratum basal moves upwards to stratum spinosum, where it divides multiply and it becomes extremely dense. And dense means there is increased production or increased activity of a cell, and cell to cell attachment is by desmosomes. Till that, is it clear? Yes. Now the cells from the stratum spinosum, they start to move upward. What is upward layer? Exactly, stratum granulosum. So stratum granulosum, as the name implies, is formed by keratohyaline granules. Okay, keratohyaline granules and Odland bodies or lamellar granules. Lamellar granules. Okay, so stratum granulosum, as the cell moves upward, it is going to form a lot of granules. So there's going to be formation of keratohyaline granules, there's going to be formation of lamellar granules, and also a very important thing is the cells, they start to become degenerate. That is, the nucleus of a cell starts to degenerate, or pycnosis takes place. Degeneration of a nucleus is called as pycnosis, flattened nucleus. So the nucleus becomes flat or it starts to disappear. Okay, so stratum basal, the cell was extremely normal. Stratum spinosum, it becomes polyhedral. Stratum granulosum, it starts to die. Very simple, right? So these keratohyaline granules, what it does is, it will just discharge all the contents of the cell on the topmost aspect of stratum granulosum. Okay, so these granules, they discharge all the contents. When I say the word discharge all the contents, that means the cell is dead. Okay, so these keratoilin granules, along with the help of certain proteins, involucrins, lollicrins, with the help of these proteins, the keratohyalin granules, they shed all their contents, and that becomes a layer of dead cells, right? This layer is called as stratum corneum, and these granules, they shed all their contents. This dead layer is called as keratin. This dead layer is called as keratin. So what is the keratin made up of? It is made up of keratoidin granules and some proteins like involucrins and lollicrins. So basically keratin is a dead layer. It acts as a waterproof barrier. Okay, so whenever I'm going to have a turnover, this turnover means the cells die over a period of time. There's a turnover rate for every cell. Say for example 1 to 6 days. Okay, 1 to 6 days for junctional epithelium, and around 10 to 12 days for gingiva, and for palate, cheek, tongue, it will be 5 to 6 days. Okay, for palate, cheek and tongue it will be 5 to 6 days. So every cell will die, will turn over. Okay, so once a cell dies, that is once the keratin layer is lost, certain basal will synthesis mitochondria, DNA, this process continues. This is what a keratinized epithelium will look like. So keratinized epithelium will have the topmost layer keratin, which is nothing but a dead cell, which is a waterproof layer. Now what is the significance to oral cavity? Very simple. The junctional epithelium and the sulcular epithelium is non-keratinized. What does that mean? Very simple. You will not have the top two layers. So stratum granulosum and corneum. If you don't have granulosum, obviously there is no keratoid granules, there is no shedding of contents, so there will be no corneum also. So there will be no stratum corneum and granulosum. So there is no waterproof barrier. There is no waterproof barrier. That is why the sulcular epithelium and the junctional epithelium becomes a semi-permeable membrane. Okay, semi-permeable means it will selectively allow substances to enter and selectively allow substances to go outside. Becomes semi-permeability because of non-keratinization. No waterproof layer, no keratin. That is the reason why it allows substances to go out, substances to come in. GCF, neutrophils, leukocytes, bacteria to enter. Okay, this is the only significance. So the junctional epithelium and the sulcular epithelium are non-keratinized. Because of no keratinization, no waterproof layer, so there is no dead cell layer, so it becomes semi-permeable. Because of the semi-permeability, it allows substances to enter and substances to move out. Very simple, right? Excellent. So now what is parakeratinization? Parakeratinization is when a cell retain a pycnotic nuclei. Okay, it does not completely die. At the same time, it will have stratum granulosum, but it will retain the pycnotic nuclei. That is called as parakeratinization. Sorry, parakeratinization. Okay, now the first one what you are going to see is the oral epithelium. Oral epithelium, if you see, it is keratinized stratified squamous epithelium. It will have a few cytokeratins. Now you should be very familiar. What is cytokeratins? Cytokeratins are nothing but proteins which will make up the cytoskeleton, and the cytoskeleton plus the cytokeratins form the keratinocyte. Okay, every cell will have a keratinocyte. If it will differentiate or not, it depends upon the epithelium, but every cell will have cytokeratins, keratinocytes. Okay, Now it is keratinase. Oral epithelium is keratinase stratified squamous epithelium, and there will be a few cytokeratins present: K1, K2, K10, K11, K12. So these are all the few cytokeratins which will be present in the oral epithelium. Okay, this will become the oral epithelium. Now coming to junctional epithelium. Junctional epithelium is very important, and it is very easy as well. Okay, I'll tell you how. See, we probe, right? We do periodontal probing. Where does the probe hit? The probe hits exactly at the coronal portion of the junctional epithelium. Okay, so whenever the junctional epithelium migrates down pocket, there's going to be increased probing depth. Okay, okay. Now this, as you would have all read in oral histology, I'll just brush it up. So the crown of a tooth, before erupting, it will be covered with reduced enamel epithelium, which will be made of cells of flat cuboidal cells and cells of stratum intermedium. So what happens, these reduced enamel epithelium, it will come in contact with the oral epithelium, and during this eruption phase, the oral epithelium gets converted into the junctional epithelium. Okay, so a few facts about junctional epithelium. Okay, a few facts about junctional epithelium. The length of the junctional epithelium will be 0.25 to 1.35 mm. It will taper coronally. It will taper. So coronal in 10 to 30 cells, apical in 1 to 2 cells. Okay, it will taper apically. So coronal end there will be more, apical end it will be less. Okay, okay. Now one very important feature about a junctional epithelium is it will have two basal lamina. Any epithelium in the body you take, it will have only one basal lamina, but only junctional epithelium will have two basal lamina. Okay, I'll tell you how. See, you take a look at this picture. Okay, what is basal lamina? Basal lamina is something which is present at the bottom of the epithelium that connects your epithelium to the connective tissue. Okay, so that is what is called as basal lamina. So see, this is one basal lamina. Sorry, see, this is your CEJ. Okay, this is one basal lamina. And this is another basal lamina. So you take a look at this basal lamina. This is called as internal basal lamina. This is called as internal basal lamina. So internal basal lamina connects the epithelium to the tooth. Okay, internal basal lamina connects the epithelium to the tooth via hemidesmosomes. Via hemidesmosomes. Desmosomes, hemidesmosomes, integrins, all these are connection proteins. A cell to cell connection, cell to basement membrane connection. So the basal lamina is connected to the tooth by hemidesmosomes. Cell to cell connection, desmosomes. Okay, so the external basal lamina is the one that connects the basal lamina to the gingival connective tissue fibers. As I told you, junctional epithelium below first diagram. Junctional epithelium, below the junctional epithelium you have gingival connective tissue fibers. Below the gingival connective tissue fibers you will have periodontal ligament fibers. So the combination of junctional epithelium plus the connective tissue fibers will form your biological width. Okay, so that is very important. So this external basal lamina connects your epithelium to the gingival connective tissue or lamina propria. Okay, so the unique feature of a junctional epithelium is it will have two basal lamina. One is internal, another one is external basal lamina. Internal basal lamina connects the epithelium to the tooth, and external basal lamina connects the epithelium to the connective tissue. Okay, now I'm going to call the cells of the internal basal lamina as dat cells. Okay, as dat cells. What do you mean by dat cells? Sorry. Dat cells are nothing but directly attached to the tooth cells. Directly attached to the tooth cells. What is dat cells? Dat cells are directly attached to the tooth cells. Okay. So this is what you should know about junctional epithelium. Now, what are the cytokeratins present in your junctional epithelium? K19, K5, K14. So these K5 and K14 are nothing but stratification specific cytokeratins. Stratification specific cytokeratins. Okay, so the cytokeratins which is present in your oral epithelium are K1, K2, K10, K11, K12. The cytokeratins which are present in your junctional epithelium is K19, K5 and K14. So K5 and K14 are stratification specific cytokeratins. Okay, so what is the function of a junctional epithelium? As I told you, junctional epithelium is a non-keratinized. It's a non-keratinized stratified squamous epithelium. Non-keratinized stratified squamous epithelium. Okay, as I told you, any cell which is non-keratinized will become semi-permeable. Any cell which is non-keratinized is semi-permeable, which means it will selectively allow substances to move in and move out. It will selectively allow substances to move in and out. Okay, so when I say a cell is non-keratinized, it becomes semi-permeable. So cells will move in and move out. In that way, junctional epithelium has advantages and disadvantages. Okay, what is advantage? You just tell me. Yes, it will allow GCF to come out. GCF obviously will have defense cells. It helps to fight, or it will act as a biomarker so that you can identify whether the patient is having disease or not. GCF, leukocytes, or cells of inflammatory cells like neutrophils. So again, if there is minimal bacteria, these cells will fight and does not allow the bacteria to enter into the epithelium. It prevents it from patient having periodontitis. Very good. And antibody production. Okay, so whenever the bacteria comes, junctional epithelium, there'll be some innate immune cells which will be present in your junctional epithelium, like dendritic cells and a few cells which I'll discuss when I talk about the host response. So these cells of innate immunity, dendritic cells, natural killer cells, Merkel cells. So these cells, what it will do, it will stimulate or it will increase the production of antibodies. Okay, so these are all the few advantages, and also it will have certain antimicrobial peptides. It itself will fight against some infections, antimicrobial peptides like cathelicidins. Okay, it will have some antimicrobial peptides like cathelicidins. Okay, cathepsin. All these are antimicrobial peptides. All these are antimicrobial peptides that will help to fight against the bacteria. So these are all the few advantages of a junctional epithelium. GCF, leukocyte, antibody protection, antimicrobial peptides, all these are going to fight against the bacteria. That is good. Again, the other aspect of junctional epithelium, because it is semi-permeable, it will also allow substance to enter, right? So what is the disadvantage? Exactly. So the disadvantage of junctional epithelium is it will allow the bacterial products to enter. It will allow the bacterial products to enter into the connective tissue and destroy the connective tissue. Once the connective tissue are destroyed, we call them as pocket. So the junctional epithelium migrates downwards. Okay, this is what is advantages and disadvantages of junctional epithelium. Okay, so what are the cytokeratins? K19, K5, K14. Okay, fine. Now coming to sulcular epithelium. So sulcular epithelium, basically it is lined by non-keratinized stratified squamous epithelium, similar to junctional epithelium. Non-keratinized stratified squamous epithelium. Okay, it is lined by non-keratinized stratified squamous epithelium, which is very similar to junctional epithelium, semi-permeable. Okay, what are the cytokeratins present in sulcular epithelium is K4, K13. Okay, these two cytokeratins will be present in sulcular epithelium. There can be K90. Okay, so these are all the few cytokeratins which is present in your sulcular epithelium, and all these will have cytokeratins. Okay, you should know now. By the time you should know what is cytokeratins, what is keratinocyte, what is keratinization, what is parakeratinization, what is a keratin layer, and so on. Okay, there should be no doubt about keratinization from now on. I hope you understand. Okay, now coming to another aspect of another feature of a microscopic feature is, first we talked about epithelium. Now we are going to talk about the connective tissue, gingival connective tissue. The combination of the junctional epithelium plus the gingival connective tissue fibers is called as biological width, which is replaced by the term supracrustal tissue attachment 2.04. Okay, no, don't get confused or don't forget that it is replaced by the term supracrustal tissue attachment. You are not going to hear the terminology biological width in your entire question paper. Okay, fine. Now moving into the gingival connective tissue. See, does your epithelium has blood supply? Does your epithelium has blood supply? Think and tell me. No. Exactly, your epithelium will not have blood supply. Then how it survive? It should die, right? It should get necrosed. How does your epithelium, which does not have a blood supply, survive? Very simple. It gets the nutrients from the connective tissue by a process called diffusion. So it will just allow the cells of the connective tissue, the nutrients especially, to enter, and it feeds the nutrients and it survives. Okay, so any connective tissue will have cells, fibers, and ground substances. Any connective tissue will have cells, fibers, and ground substances. Now the fibers, okay, it will have cells, it will have fibers, it will have connective tissue. Okay, so now just imagine we are going to talk about the gingival connective tissue fibers. Just recollect your diagram. Junctional epithelium, dot cells, gingival connective tissue fibers. Below that you have periodontal ligament fibers. Now we are going to talk about only gingival connective tissue fibers. Okay, now Whenever I see the word gingival, whenever I see the word gingival, it means it is the lamina propria, which is nothing but the connective tissue. Whenever I see the word gingival, it represents lamina propria, which means the connective tissue. Okay. Whenever I see the word dento, it means it represents CJ. Okay. Now, dentogingival fibers. CJ to the lamina propria. What is that lamina propria? Don't get confused. See, you take a look at this. Okay. See, this is your junctional epithelium. This is your gingival connective tissue fibers, and this is your PDL. Let us imagine. So now, whenever I say the word lamina propria, it means these fibers just end here. It does not have an attachment. Okay, say for example, CJ to the bone, it's attached. But when I say gingival, it means it extends from the CJ to the lamina propria. This center portion, it ends here. Okay, the entire gingival connective tissue is called as lamina propria, but why they are specifically telling it ends in the lamina propria is it does not have that side attachment, so it just extends from the CJ into the gingival connective tissue. That is a very simple terms. Extend from the CJ to the gingival connective tissue, that is lamina propria. So dentogingival, from the CJ just enter into the connective tissue. Alveologingival, very important. Alveolo means it represents periosteum of the alveolar bone. Okay, it represents the periosteum of the alveolar bone, especially the crest of the alveolar bone. So, which means the fibers will be originating, the fibers, okay, the fibers will be originating exactly from here. So, alveologingival, from the periosteum of the alveolar crest enter into the lamina propria. From the periosteum of the alveolar crest enter into the lamina propria. Okay. Interpapillary. Okay. Interpapillary means between the two papilla. Transgingival fibers. Transgingival. Okay. It is nothing but from, as you can see the number, transgingival. It extends into the lamina propria. It just connects one tooth to the other. Okay, transgingival, within the gingiva. Okay, now I'll tell you a few other terms. Circular fibers. Circular fibers means it just circles the tooth above the crest of the alveolar bone. Okay, dentoperiosteal fibers. Cementum to the periosteum, but since we have already know a fiber extending from the alveolar crest, okay, since we already know a fiber originating from the alveolar crest which is alveolar gingival, this dentoperiosteal extends from the cementum into the periosteum of the alveolar process, that is the lateral aspects. Okay, not on the crest. So it is not originating from the crest, rather it will just end in the lateral aspect. Okay, that is called as periosteogingival. Okay, intercircular fibers. It extends from the cementum of one tooth, splay out and end in the cementum of another tooth. Okay, intergingival means it is present just below, just adjacent to the epithelium, and it will just run throughout the gingiva, connecting one tooth to other. Another group of fibers called transeptal fibers. They extend from cementum of one tooth to the cementum of another tooth. The transeptal fibers is very important because they have the capacity to regenerate and they are not destroyed they are not destroyed most of the times in trauma from occlusion. That is the reason why you don't have a pocket in trauma from occlusion, but you will have a bone loss. Okay, that is the reason why you don't have a pocket in trauma from occlusion, but you will have bone loss. Okay, we'll discuss that in trauma from occlusion class. Okay, so these are all the few gingival connective tissue fibers. What is the function of gingival connective tissue fibers? All these fibers are collagen. You see how densely packed it is. That is the reason for tissue barrier concept. Dense collagen fibers, they are more resistant to inflammation than the loose connective tissue fibers. Okay, so this is the reason your gingival connective tissue will be extremely densely packed, that will resist the bacteria to enter into the tissues. Okay, fine. Now next one, what you are going to see is the fibroblast. Connective tissue is done. Next what you are going to see is the fibroblast. See, fibroblast as such, if you see, it has two functions. One, it can synthesis collagen, okay, and help in wound healing or normal turnover. Okay, another one is it will extend phagocytic process. It can release collagenases, it can synthesis collagenases that can destroy collagen. So fibroblast can synthesis collagen, fibroblast can destroy collagen depending upon the need. Okay, so there is no cell called fibroclast. Okay, very good. Now blood vessels, nerves, you will read in anatomy. Matrix. So matrix are nothing but ground substances. Okay, matrix are nothing but the ground substances. So what is the function of a ground substance? It helps to retain the cells in the connective tissue, retain the cells in connective tissue, and also it helps for the electrolyte and nutrient transfer. Okay, so it retains the cells in the connective tissue, electrolyte and nutrient transfer. So if you take just imagine that connective tissue of gingiva, it will have cells, it will have fibers, it will have ground substances. Cells, there are n number of cells: fibroblast, osteoblast, cementoblast. All these cells will be present. Some precursor cells will also be present, and also the fibers, the densely packed collagen fibers, and the ground substances. So the ground substances, as I told, it is used to hold all the cells of the connective tissue and also for the electrolyte and nutrient supply. Okay, so this is what the microscopic features of gingiva is all about. We have talked about epithelium, the sulcular, junctional, and the oral epithelium. We have talked about what is keratinization and what are the various cytokeratins present, and we have talked about what are connective tissue aspects, cells, fibers, and matrices. Macroscopic features, three parts of gingiva, and also we have talked about the color, contour, consistency, shape, surface texture of the gingiva. Okay, with this, the basic tissue, the first basic tissue, gingiva, gets over. I hope everything is clear, and we will see you in the next video. Thank you so much for watching this video. Have a great day.